Welcome all to the today's class. Today we'll continue with the maternal medicine module, and it is the endocrinological topics which we are going to cover now. Okay, so today's GTG is for discussion thyroid new GTG, and that I have divided into three different parts. The first part is related to the thyroid physiology, thyroid function test, and its implication. This topic is going to be very important, so please concentrate. Okay. So let's see what happens to the thyroid physiology during the pregnancy. Okay, so basically during pregnancy, the thyroid hormone demand is increased by around 50%, and this is mainly because of the maternal plus fetal needs. Because we know that the fetal thyroid will start functioning maybe around 20-22 weeks of gestation. So till that time, the fetus is dependent on the maternal thyroid. So there is an increase in the hormone demand by around 50%, and this is mainly because of the increased maternal as well as fetal need. Then what happens to the TBG, that is the thyroid binding globulin? Now thyroid binding globulin are also increased in early pregnancy, but they will plateau at around 18 to 20 weeks of gestation. This is under the influence of estrogen. Okay, now what happens? Now thyroid binding globulin are increased. So once the binding globulins are increased, the free T3 T4 level will reduce. So body will try to increase the T3 T4 production, and that is why in the first half of the pregnancy, when the TBGs are increased, the body will also increase the T3 and T4 production. So but this will also study by around mid gestation, but this will maintain the free FT4 levels. Okay, so this is because of the increase in the TBG which is happening early, and that gets stabilized by around 18 to 20 weeks of gestation. So simultaneously, it will be reflected that the T3, T4 production will be increased in the first half, and it will become steady in the mid gestation. Now, if you see the pregnancy hormone, that is SCG, that will also drive this FT3, FT4 production, because the SCG has got the TSH like action. So there will be increase in the FT3, FT4 levels, and there will be decrease in TSH level. That is seen mainly in the first trimester. However, once the SCG levels go down, this effect is not that prominent. So in latter pregnancy, there is a little reduction in the FT3, FT4, but there is a slight increase in the TSH level. And this is mainly because of the decrease in the SCG. Hello?
Yes, sir.
Can you hear or no?
Now I can make.
Yeah, yeah,
Yes, sir.
yeah. Let's see about the iodine metabolism. So what happens to the iodine metabolism? There is a requirement of increased. This is mainly because of the increased thyroid hormone synthesis. There is increased renal iodine clearance. There is a placental iodine storage, and there is a fetal thyroid uptake from around 10 to 12 weeks of gestation, and the breast milk production, which begins in the second half, also requires the this iodine, because again for the fetus the breast milk will be the source of the iodine, and the breast milk production will begin in the second half of the pregnancy itself, and that is why the iodine requirement is increased. The fetal iodine uptake will begin around 10 to 12 weeks of gestation, but the thyroid gland functioning proper, or the thyroid secretion synthesis, will start around 20 weeks of gestation, that we will see. Okay, around 18 to 22 weeks it starts. So in fetal thyroid development, iodine uptake begins at around 10 to 12 weeks of gestation, but the thyroid hormone production will begin at around 18 to 22 weeks of gestation. Okay, these few things do remember from SBA point of view. Okay, so the fetus is completely dependent on the maternal T4 in early pregnancy. Maternal T4 is essential for neurodevelopment, which is critical in the first half. Maternal iodine supply is required throughout the pregnancy. Okay, so importance of maternal thyroid hormone is mainly it is important for the maintenance of the pregnancy. It influences the placental development, and it is also essential for the fetal brain development. Now, what happens in iodine deficiency? Okay, if there is a severe iodine deficiency, now how this iodine deficiency is measured? It is measured by urinary iodine levels. Okay, so by definition, if the level is less than 20 microgram per liter, we call it as a severe deficiency. Okay, so actually this screening is not done, but when we talk about severe iodine deficiency, this is what is the unit which is used, that is the urinary iodine level less than 20 microgram per liter. Okay, and what are the risk of this iodine deficiency? There will be goiter, hypothyroidism, miscarriage, infant mortality will be increased, there will be neurodevelopmental impairment, then intellectual disability will be there, there will be deafness, mutism, and motor rigidity. Okay, so thyroid nodules are seen in up to 30% of the pregnant women. Okay, so these are the things which are associated with the severe deficiency. If the deficiency is mild to moderate, there is mainly the goiter and the thyroid disorders, and generally it has got a possible association with the preterm birth and small for gestational age babies. Neural development, such as there is a decrease in the executive function, that is the brain higher functions will get affected. There will be attention deficit and hyperkinetic disorder, and the cognitive disorders will also be there if there is a mild to moderate iodine deficiency. Okay, so if there is a sufficient iodine in that particular area, generally the minor variation in the iodine uptake will be managed by the thyroid gland. Okay, so variations in the iodine, there is a minimal effect on the neonatal outcome because body has got, thyroid has got that much of adaptability. When the iodine replete or there is a mild deficiency area, in that particular case, what could be the cause for the autoimmunity? If the thyroid gland is able to manage, then in that particular cause will be the autoimmunity, and that is the most common cause where there is a sufficient iodine level or just mild deficiency areas. The autoimmunity is the most common cause for the thyroid disorders. Okay, so what are the risks of the untreated thyroid disease? One, there can be overt hypothyroidism. Second, there can be overt hyperthyroidism, and that will lead to complications such as, in overt hypothyroidism, you will get miscarriage, you will get perinatal death, preeclampsia, preterm birth, low birth weight, postpartum hemorrhage. So hypothyroidism will have the multiple complication, obstetric complications, while hyperthyroidism, mainly the preterm birth, preeclampsia, FGR, and the maternal heart failure. These are the associations of the overt hyperthyroidism. Okay. Now coming to the hyperthyroid state in pregnancy. Okay. Now this hyperthyroid state, one, it can be gestational transient thyrotoxicosis. This concept you need to understand because there can be SB on this. Okay. So the concept of gestational transient thyrotoxicosis, around 1 to 5% of cases, this can be there. Then patient may be having pre-existing Graves disease, around 0.5 to 1.3% of cases. There may be new diagnosis of the Graves disease in around 0.05% of cases. That means one case in 2000. Okay, or 0.5%. Okay, or there can be toxic nodal goiter, which is rare. That is around 0.1%. That is 1 in 1000. Okay. So, first is a gestational transient thyrotoxicosis. Okay, it is quite common, around 1 to 5% of cases, but it is benign, self-limiting condition, and no treatment is required. And this is very important. When you diagnose thyrotoxicosis, you need to differentiate it from the Graves disease because the management is totally different. For Graves disease, there will be thyroid receptor antibody mediated. It will be there. Then it often improves with the gestation and it requires the treatment. Okay, so these are the things which are associated with the Graves disease. One, it will be thyroid receptor antibody mediated. It improves with the gestation. Third, it requires the treatment. Okay, now coming to the subclinical hyperthyroidism. Okay, now what we mean by subclinical hyperthyroidism? That means T3, T4 levels are normal, but TSH level is low. Okay, so TSH level is low, but T3, T4 levels are normal. So, subclinical hyperthyroidism. Subclinical hyperthyroidism, that means TSH level is low, but T3, T4 level are normal. So outcome is that no adverse effects, management, no treatment is required. Okay. So this is very clear. Subclinical hyperthyroidism, where T3, T4 levels are normal, but TSH level is low, no treatment is required, and it does not have the adverse outcome. Now let's talk about the thyroid autoimmunity. Okay. So common antibody which is seen is a TPO antibody. Okay, peroxidase, thyroid peroxidase antibody. Prevalence is around 5 to 31%, and in infertility and miscarriage patient, it is around 10% of cases. Okay, so clinical association, patient may be euthyroid. Okay, and there may be presence of TPO antibody. So what is the risk? These patients are at risk of miscarriage, preterm birth, postpartum thyroiditis. Okay, but if you have got a TPO antibody and thyroid dysfunction, Along with this, the patient will be at a risk of development of the preeclampsia and the gestational diabetes mellitus. Okay, so that is what is the significance of TPO antibody. TPO antibody with euthyroid gland, there is increased risk of miscarriage, preterm birth, and postpartum thyroiditis. But if there is a thyroid dysfunction associated with the TPO antibody, then additional risk will be, apart from this, there will be preeclampsia and the gestational diabetes mellitus risk. Okay. Now, another thing is that there can be thyroid nodule or the goiter. Okay. Now, this is clinically apparent nodule, but generally it is rare in pregnancy. UHG nodules that may be with age and parity, there may be slight increased incidence. Okay, but when you detect such nodules, you need to assess one, is there any compression symptom? Second, exclude the malignancy and hyperthyroidism. Okay, so what are the controversies about the screening for the thyroid? Whether should we do this thyroid test routinely or should we do it selectively? So that is controversial. And should we treat subclinical hypothyroidism or isolated hypothyroxemia? And is there a benefit? That is totally unclear. But what does the guideline say? That we will discuss in subsequent session. Okay. So what are the clinical care principles? First, avoid under treatment. Second, avoid over treatment. Third, do not delay any treatment. Okay. So delay should not be done. Under treatment is to be avoided and over treatment is to be avoided. Okay. Care should be optimized, preconception, antenatal, and the postpartum also. Okay. Now let's see about the care which is to be given as far as the thyroid function is concerned. So there should be designated primary clinician. It should be multidisciplinary team approach. So you should have the obstetrician plus endocrine consultant managing these conditions. Now let's talk about the thyroid function test in pregnancy. Now for thyroid function test, there are two things you should remember. One is a trimester specific range and second is a manufacturer specific range. These are the two things which you need to give importance. Okay, so what is recommended for pregnancy? Always use trimester specific ranges and the manufacturer specific ranges, and this is applicable for the TSH and FT4. So when we measure the thyroid, screen these patients, we do these tests TSH and FT4, and we should use trimester specific range and the manufacturer specific range. Okay, so in pregnancy, these specific ranges, if these specific ranges are not available, then the TSH upper limit of 4 milli international unit per liter can be used as a cutoff. Okay, but this is mainly for the study, but lab will always give the trimester specific ranges. Okay, but the trimester specific is not available, then 4 milli international unit per ml can be used. Okay, then treatment targets and diagnostic ranges. These two are different concepts. Okay, for diagnostic purpose, we should use the trimester specific range and the manufacturer specific range. While for treating the target, so these levels are different, that we will discuss when we will discuss the hypothyroidism or the hyperthyroidism. Okay, so for diagnosing the thyroid disease, use the pregnancy specific ranges. If the lady or the woman is on treatment, then go for the treatment targets, that is the TSH and FT4 level. Okay, but for diagnosing the thyroid disease, pregnancy specific ranges are to be used. This is the thing which you should remember. Okay, and regarding the treatment range, that we will see subsequently when we will deal with the hypothyroidism and the hyperthyroidism. Okay, so important rule is that do not use treatment targets for the diagnosis. So the treatment targets are not to be used for the diagnosing the thyroid condition. Okay, treatment targets will improve the outcome. Then iodine and supplementation strategy in pregnancy. So pregnancy and breastfeeding, how much is the requirement? Requirement is around 200 to 250 microgram per day. And how to achieve this requirement? By increasing the dietary iodine rich foods, or supplement 150 micrograms of iodine in form of potassium iodide. Okay, so timing of supplementation, ideally 3 months before conception or as early as possible in the pregnancy, and the dose of supplementation is around 150 microgram. Okay, so total this pregnancy and breastfeeding requirement is 200 to 250. Supplementation is around 150 microgram, and we should not give more than 500 microgram per day. Okay, so take single supplement only. Avoid intake more than 500 microgram per day. And maternal plus thyroid dysfunction risk will be there if there is an excess of iodine intake. So you should remember these few figures. Okay. Now coming to the iodine status testing, as already I have mentioned that it is not recommended. Individual iodine assessment, urinary iodine 24 hours not done because these are not reliable for individuals. Okay. Now coming to the testing for thyroid disease in pregnancy, should there be universal screening? Universal screening is not recommended because there is no improvement in overall outcomes if you screen for all. Okay. So what is indicated is a targeted screening. Okay. So which population we have to test? The high risk women only will be testing. The timing is as early as possible in pregnancy, preferably in the first trimester. The test which is recommended is a TSH and FT4. Simultaneously, you have to do. It avoids the delay in the diagnosis and enables early treatment. Okay. So risk factors for the testing, there are various risk factors. If the patient has got some thyroid history, that is the previous thyroid disease, either overt or subclinical, or previous thyroiditis such as autoimmune, infectious or postpartum, or she is a known case of TPO antibody positive, or there may be structural or clinical history of thyroid surgery or goiters, thyroid nodule, radioactive ablation, head neck irradiation, etc. Or she may be taking another antithyroid drug such as amiodarone or lithium, which are known to affect the thyroid gland function. You have to test this lady. Okay. Then clinical features such as she is presenting with clinical features of cardiac dysrhythmias, significant weight loss, enlarging thyroid gland. Okay. Then autoimmune and medical conditions such as type 1 diabetes, SLE, anti-Rho, anti-La positive, or antiphospholipid antibody syndrome. We'll be testing these ladies for thyroid. Okay. Then obstetric history such as stillbirth, second trimester miscarriage, previous late pregnancy loss, again is an indication for the testing for the thyroid. So from examination point of view, we should remember there is an increase in the thyroid demand by around 50% in the pregnancy. Normally, because of the SCG, there is a decrease in the TSH levels in the first trimester. Fetus will depend upon the maternal T4 until around 18 to 22 weeks of gestation. By that time, the fetal thyroid gland will become functional. Severe iodine deficiency may lead to the neurodevelopmental effects. Then gestational transient thyrotoxicosis is common but does not require treatment. Then subclinical hyperthyroidism also does not require treatment. There is a autoimmunity, which is the most common cause. Okay, overt thyroid disease may lead to the major maternal and fetal risk. Always use trimester and the SS-specific ranges. If it is not available, the TSH upper limit of 4 can be considered. Do not mix the treatment targets with the diagnostic ranges. Okay. Then iodine requirement is around 200 to 250 microgram per day. Supplement dose is around 150 micrograms of potassium iodide. Avoid excess iodine more than 500 microgram per day. No individual iodine testing. It is not recommended. Universal screening for thyroid function is also not recommended. We have to do only targeted screening as I have mentioned in the session, and that should be done in the first trimester, and always test for TSH and FT4 together. Okay. So that is what is about the physiology of the thyroid in pregnancy. Okay. So the first part of the thyroid physiology of this particular guideline we have finished. Now we have few SBA questions. Doctor, can you please go through these questions?
Yes, sir. A 26-year-old woman at 9 weeks of gestation has following TFT, TSH slightly low and free T4 mildly elevated. She is asymptomatic. What is most likely physiological explanation? A. Increased estrogen causing TSH suppression. B. HCG mediated stimulation of thyroid. C. Increased renal iodine clearance. D. Placental deiodinase activity. Or E. Fetal thyroid hormone production. It is B. HCG mediated stimulation of thyroid.
Yes. Okay, so it is a SCG mediated stimulation of thyroid. SCG has got a weak TSH like activity, so it leads to the increase in FT3 and FT4 levels, and there is a decrease in TSH in the first trimester. That is a physiological change. Okay, so avoid overdiagnosis. Next.
A pregnant woman asks about thyroid physiology. When does thyroxine binding globulin typically plateau? A. 6 to 8 weeks. B. 10 to 12 weeks. C. 14 to 16 weeks. D. 18 to 20 weeks. E. 24 to 28 weeks. It's D 18 to 20 weeks.
So it should be around 18 to 20 weeks. So TBG raises early due to the estrogen levels, but it plateaus by around 18 to 20 weeks of gestation. Next.
At what gestational age does the fetus begin producing significant thyroid hormone? 6 to 8 weeks, 10 to 12 weeks, 14 to 16 weeks, 18 to 22 weeks, 24 to 28 weeks. It is 18 to 22 weeks.
Yes, it is 18 to 22 weeks. Okay. So second half, by second half, generally it's has started functioning. Okay. So before this, fetus is fully dependent on maternal T4, and that is the early period is the critical for neurodevelopment. Okay. Next.
Which of the following is not a reason for increased iodine requirement in pregnancy? Increased thyroid hormone synthesis, increased renal iodine clearance, placental iodine storage, increased hepatic metabolism of iodine, fetal iodine uptake. It is D, increased hepatic metabolism of iodine.
Yes, otherwise rest things requires iodine. So increased hepatic metabolism of iodine is not a reason for increased demand. Okay, so true causes will be increased hormone synthesis. There is increased renal loss, placental use is there, fetal uptake is there, hepatic metabolism is not there. Okay, next.
Which of the following is the most serious fetal outcome of severe iodine deficiency? A. Low birth weight. B. Preterm delivery. C. Neurodevelopment impairment. D. Gestational diabetes. E. Polyhydramnios. It is C. Neurodevelopmental
Yes,
impairment.
neurodevelopmental impairment is seen. So severe deficiency leading cause of preventable neurodevelopmental defects. It includes the intellectual disability and the deaf mutism. Next.
A pregnant woman has low TSH, normal free T3 and T4. She is asymptomatic. What is the best management? Start PTU, start carbimazole, start levothyroxine. No treatment is required. Repeat TFT weekly. It is no treatment is required. D.
D. Okay. Do we have to repeat?
No need.
No treatment is required. It is a subclinical hyperthyroidism, not associated with the adverse outcome. No treatment is required. Next.
A laboratory does not provide pregnancy-specific TSH reference ranges. What is the most appropriate upper limit of TSH to use? That is D 4.0 million units
Yes,
per
4
liter.
million. Okay, D. Okay, if no pregnancy specific range, use TSH upper limit of 4 million units per liter. That is a pragmatic approach. Next.
A pregnant woman is being evaluated for suspected thyroid disease. Which approach should be used for interpretation of TFT? A. Treatment targets for TSH. B. Non-pregnant reference ranges. C. Trimester-specific pregnancy ranges. D. Fixed TSH cutoff of 2.5. Only free T4 levels. The C. Trimester-specific pregnancy ranges should be used.
Yes, we should use for diagnosis, always go for trimester specific. Okay, for diagnosis, use pregnancy specific reference range. For treatment targets, used only in known thyroid disease. Okay, next.
A pregnant woman is taking multiple prenatal supplements containing iodine. What is the main risk? A. Iodine deficiency. B. Maternal hypothyroidism only. C. Fetal hypothyroidism only. D. Maternal and fetal thyroid dysfunction. E. No clinical risk.
Multiple prenatal supplements containing the iodine. It will have effect on what?
No clinical risk. She is taking iodine supplementation.
She is taking iodine supplementation, but there are recommendation how much supplementation,
Oh,
and it should be done. It should be single intake only, daily. It should not be in bulk also. Okay,
D.
so it will lead
D.
to the maternal and fetal thyroid
Fetal.
dysfunction. Okay, so excess iodine more than 500 microgram per day can cause thyroid dysfunction in both mother and fetus. Avoid multiple supplements. Okay, next. And that also 150
Clinic
microgram. Requirement is 200 to 250, but
200
supplement
to
should be 150, and it
150.
total should not exceed more than 500. Okay,
Yes.
next.
A clinician plans to assess the iodine status using urinary iodine levels in an individual pregnant woman. What is the most appropriate advice? Recommended as gold standard, useful if repeated weekly, useful only in first trimester, not recommended for individual assessment. Only 24-hour collection is valid. It is not recommended for individual assessment.
Yes, it is not recommended for individual assessment. Urinary iodine valid for population studies and not reliable for individual. Okay, next.
Hospital is planning to introduce universal thyroid screening at booking. What does current guidance suggest? Strongly recommended, recommended only in high risk countries, not recommended routinely, mandatory in first trimester, only TSH screening is required. Is recommended in high risk countries.
Not recommended routinely. Okay, routinely not recommended. Universal screening is not recommended. No proven improvement in the outcome. The guideline talks about the
High risk
only,
patients.
yeah. Okay,
Okay.
next.
A 34-year-old woman with type 1 diabetes presents at 7 weeks gestation. What is the most appropriate investigation strategy? A. No testing is required. B. TSH only. C. Free T4 only. D. TSH and free T4 together. E. TPO antibody only. So it is D. TSH and free T4 is done together
Yes,
at the
because
same time.
she's autoimmune disease is an indication for thyroid screening, and thyroid screening you will do with two TSH plus FT4. Okay, and there are many other also like clinical feature, previous history, etc., etc. So high risk patient we will do testing, and the test used is a TSH and FT4 simultaneously. That will avoid the delay in diagnosis. Next.
30-year-old primate at 9 weeks of gestation undergoes TFT for the first time. She is asymptomatic. Her TSH is 3.8, free T4 is normal. Laboratory does not provide pregnancy-specific reference ranges. What is the most appropriate interpretation? TSH elevated, diagnose subclinical hypothyroidism. B. TSH is normal, no thyroid dysfunction. Use treatment target TSH less than 2.5 abnormal. Repeat TFT in second trimester before diagnosis. Diagnose overt hypothyroidism. It is B, so TSH is normal and there's no thyroid dysfunction
Because the lab has not provided this,
provided, and upper limit is 4.
yeah, and otherwise any other thing which they have given, that she's asymptomatic. Okay,
Asymptomatic.
asymptomatic. Okay, so TSH is normal, no thyroid dysfunction. So confusing treatment targets and versus diagnostic cutoffs. Okay, if no risk, reference range, TSH of upper limit of 4 is to be taken. TSH 3.8 is within normal limit. Do not use treatment target of less than 2.5 for the diagnosis. Okay, next.
A 28-year-old woman planning pregnancy is taking prenatal vitamin containing 150 microgram iodine, additional iodine supplement of 100 microgram. She asks if this is appropriate. What is the best advice? Continue both as total is within the recommended intake. Stop all iodine supplements. Continue only prenatal vitamin. Increase iodine to 300 microgram daily. Measure urinary iodine load. Decision. The C. Continue only prenatal vitamin.
Yes, continue
150
only
microgram
one.
iodine.
Continue only prenatally. Okay, so 150 plus 100 will be 250. Though total requirement, but supplement recommended is only 150. Okay, avoid multiple iodine supplements and avoid risk of excess also. Okay, next.
A 33-year-old woman presents at 8 weeks of gestation. She has no thyroid history, BMI is 24, no autoimmune disease, and there is history of second trimester miscarriage not previously investigated. What is the most appropriate thyroid testing strategy? A. No thyroid testing is required. B. TSH only. C. Free T4 only. D. TSH and free T4 simultaneously. E. TSH, free T4 and TPO antibody. No
So
thyroid testing is required for this.
she has got history of second trimester miscarriage, not previously investigated. Otherwise, nothing else is there.
No other high
So
risk
his
factor.
second trimester miscarriage, should we consider as a high risk for thyroid disorder and do TSH and FT4, or we should do no go ahead with the no thyroid testing? Okay, let's
Mostly it
see.
is E,
The
sir.
TSH and FT4 we should do because keep missing obstetric risk factor. Second trimester miscarriage. Targeted screening is indicated. TSH and FT4, but TPO antibodies are not routinely indicated. Okay. Next.
Okay. A 25-year-old woman at 10 weeks gestation has TFT. TSH of 0.2 million units per liter, and free T4 is mildly elevated. She has no symptoms, no goiter, and no past thyroid history. What is the most appropriate interpretation? She's having overt hyperthyroidism requiring PTU. B. Subclinical hyperthyroidism requiring no treatment. C. Normal physiological response to pregnancy. D. Gestational transient thyrotoxicosis requiring treatment. E. Central hypothyroidism.
TSH is slightly low, FT4 is mildly elevated.
It can be normal physiological response to
Yes, it is a
pregnancy
normal
during first
physiological,
trimester.
yeah, it is a normal physiological response to pregnancy. Okay, physiology versus gestational transient thyrotoxicosis versus disease. Okay, so normal physiological response to pregnancy. So it is seen in the first trimester, mild FT4, decrease in TSH, patient will be asymptomatic. It is SCG mediated physiological change. So uh, gestational transient thyrotoxicosis will be asymptomatic, may be associated, and hyperemesis, etc. will be there. Usually symptomatic gestational transient thyrotoxicosis, usually symptomatic hyperemesis will be the feature, and overt hyperthyroidism, there are no clinical signs present. Clinical signs will be present. If it is overt hyperthyroidism, there will be clinical signs. Okay. So just take home message that SCG will lead to the decreased TSH in the first trimester. Thyroid binding globulin will plateau by around 18 to 20 weeks of gestation. Fetal thyroid starts functioning by around 18 to 22 weeks of gestation. Severe thyroid iodine deficiency, there will be neurodevelopmental damage. Subclinical hyperthyroidism, no treatment is required. If no reference range, TSH of 4 milli international diagnosis, go for pregnancy specific ranges. Avoid iodine excess more than 500 microgram. No individual iodine testing is required. The universal screening for thyroid function is not recommended. We go for targeted screening, and that screening test will be TSH plus FT4 together. TSH of 4 will be the diagnosis of upper limit if no lab range is given. Never use TSH less than 2.5 for diagnosis. Then iodine single supplement only. Avoid multiple sources. Risk-based screening. Even single obstetric factor is present, go for testing. And first trimester, there is a decrease in TSH, mild T4 increase, FT4, that is often physiological. Okay.